Are my slides visible now?
Yes, madam, we can see.
I'm so sorry for the Dr. Shival had to come. I'm so sorry for the technical glitch. So I begin again and apologies again. So this was a 4-year-old male child resident of Nagaur, Rajasthan, who was admitted with us in pediatric ward on 1st of March 2023. He had a very stormy PICU stay of 25 days. Thereafter, a ward stay in pediatric ward as well as pediatric surgery ward for total 23 days, and was finally discharged on 17th April 2023. So he presented with chief complaints of fever for 10 days, 3 months back, productive cough which was persistent for 3 months, and blood and sputum 3 episodes in last 2 days, approximately 50 to 70 ml each time. So with this history, he was admitted on 5th day of illness with us in the pediatric ward of AIIMS Jodhpur. With fever and productive cough and respiratory distress. His chest X-ray and CT chest were suggestive of necrotizing pneumonia. Hence, he was admitted, received amoxiclav and linezolid for 7 days. He became afebrile for 3 days and was then discharged on oral antibiotics for 4 weeks. At home, the child was improving, but because of death of his mother during this period, his compliance with medications was not very good. However, he reported to OPD once and he was found to have no fever or respiratory distress, but cough was persisting. He then presented to us after 3 months of onset of illness with history of blood and sputum for 2 days, and was again admitted to pediatric ward AIIMS Jodhpur. There was no history of significant weight loss or TB contact, no history of any choking episode or recurrent regurgitations, no history of bluish discoloration or swelling in any part of the body or exertional dyspnea, no history of altered sensorium, recurrent boils, any deep-seated abscesses, any recurrent diarrhea or wheezy stools, or recurrent ear discharge. Past history was significant. He had 4 hospital admissions in the past 2 years with complaints of fever and cough. However, they were not forthcoming with a history of respiratory distress. However, he received IV antibiotics for 3 to 4 days each time. TB workup done outside in private hospital was negative. He was second in birth order, term, normal vaginal delivery, cried immediately after birth. His birth weight was normal. There was no NICU stay. He was immunized for age. Development was normal. Family history, as I already said, there was death of mother 2 months back due to peripartum complications, and the baby also died. There was no history of TB in family or any other significant history. So this was a 4-year-old child. He had an elder sibling who was 6-year-old, alive and healthy. So on presentation to pediatric emergency, his airway was clear and ventilatable, breathing was normal, other except air entry which was decreased on the right side, circulation parameters were normal, disability and exposure were normal. So he was classified to be stable and was shifted to pediatric ward. He had tachycardia at admission, 120 heart rate. Rest of the vitals were normal. His general physical examination was normal, other than pallor present. And on systemic examination of respiratory system, he had crusts in both the nostrils stained with blood. And on he had tactile local phlebitis increased in the right inframammary, infraaxillary, and infrascapular areas. And on percussion, there was dull note in the same areas. And on auscultation, bronchial breath, sound and air entry was reduced in right inframammary, infraaxillary, and infrascapular area. No other adventitious sounds. Cardiovascular system, CNS, and abdomen was normal. So coming to database, this was a 4-year-old boy, second born to non-consanguineous marriage, smooth perinatal transition, appropriate development, presented with fever for 10 days, 3 months back, productive cough, persistent for past 3 months, blood and sputum, 3 episodes in the past 2 days, past history of hospitalization 4 times for fever and cough requiring IV antibiotics. On examination, no respiratory distress, but findings of respiratory system were suggestive of consolidation. So we kept a provisional diagnosis of right lower zone persistent pneumonia with hemoptysis with anemia. Our differential diagnosis were community acquired pneumonia. Since he had a previous diagnosis of necrotizing pneumonia and symptoms were only partially resolved, we still kept the diagnosis of necrotizing pneumonia. Pulmonary TB was one of the differential diagnoses, but his TB workup outside and here again in our hospital was negative. His BAL CB NAT was negative. Complicated congenital lung malformation was another DD, but it was ruled out on CT. Retained foreign body leading to right lower lobe pneumonia was another DD, but ruled out on bronchoscopy. Immunodeficiency was another differential diagnosis, but there was no history suggestive of infection elsewhere other than the respiratory system. So initial course in the pediatric ward. Child was managed in ward with supportive care with IV antibiotics, amoxiclav and linezolid. As you can see the chest X-ray, he had a cavitary lesion in the right lower lobe and also non-homogeneous infiltrates obscuring the cardiac border. So the right middle lobe as well as the right lower lobe was involved. So because of persistent symptoms, pediatric surgery consultation was taken and lower lobe lobectomy was, left lower lobe lobectomy was planned. On intraoperative findings on surgery, his heart, the right lung, the upper lobe was found to be healthy. The lower and middle lobe were hepatized. There was a large pus-filled cavity in the middle lobe communicating with the segmental bronchus, causing air leak. Because of hemodynamic instability, the surgery had to be interrupted. Child was having massive hemoptysis, blood even flowing to the left side of the bronchus, and child went into hypotensive shock. So only non-anatomical lower lobectomy was done on the left side. On the right side, minor parenchymal air leaks were present. So the child was shifted to pediatric ICU post-operatively. So child was on SIMV mode, that is synchronized intermittent mandatory ventilation mode of pressure control of 6, PEEP of 6, FiO2 40%. When he presented to pediatric ICU, he was in hypotensive shock. He had a hemoglobin of 3 gram per deciliter. He was given fluid boluses and transfused PRBC. And ADR was started at 0.1 mic per kg per minute, following which the shock stabilized. On day 2, he was extubated on HFNC, but he developed fever, which was new onset. Antibiotics were upgraded to Piptaz and Vanco after sending all the cultures and repeating the sepsis screen. However, he developed bronchopleural fistula and subcutaneous emphysema on day 3. As we can see in this X-ray, we can see subcutaneous emphysema and we can see ICD in situ. ICD was adjusted and negative suction was attached after consultation with pediatric surgery team. Child was on day 4, 5, child was still on HFNC, afebrile, no worsening of subcutaneous emphysema. However, on day 6, he developed new onset fever, worsening respiratory distress, progression of subcutaneous emphysema, and he developed pneumothorax as well. He was started on non-invasive ventilation. Second ICD was inserted. Antibiotics were upgraded after sending all cultures. Probable VAP, that is ventilator-associated pneumonia, was kept. The antibiotics were upgraded to meropenem and colistin, and vancomycin was continued. Here we can see on this X-ray the collapsed lung margin, and therefore pneumothorax is present, and the 2 ICDs in situ. And here we can see there is increase in subcutaneous emphysema. On day 8, child was extubated. Child was intubated and was taken on conventional ventilation. However, he had acute respiratory distress syndrome with an oxidation index of 12. Which is classified as moderate ARDS. Also, he developed septic shock and non-ADR was started at 0.1 mic per kg per minute, and air leak was persistent. So, day 11, a subtotal pneumonectomy was planned by the pediatric surgery team. Middle lobe and lower lobe were planned to be removed, and this time the surgery was uneventful. However, after surgery, also bronchopleural fistula was persistent. Pneumothorax had resolved. Post-surgery, child's CO2 had risen up to very high levels, up to 100. Therefore, he required very high ventilatory support, and therefore we had to take the child on HFOV, that is high frequency oscillatory ventilation, which is good for air leaks or management also. So high frequency oscillatory ventilation was given for 36 hours, and thereafter he was taken back on conventional ventilation. Here we can see even evidence of VAP. We can see non-homogeneous infiltrates in the left upper and throughout the left lung fields, and as well as in the right middle lobe. So with the present management and the antibiotics, his respiratory parameters improved, and we could wean him and extubate him on day 17 of PICU stay. We extubated him to NIV support, non-invasive ventilation for 2 days. Thereafter, heated humidified high flow nasal cannula was given for 3 days, and then child was taken on oxygen by prongs. On extubation, child had features of sedation withdrawal. We assess sedation withdrawal by a withdrawal assessment tool. Any value more than 3 is positive, so he had features of sedation withdrawal, and he also developed ICU delirium because he was encephalopathic, not interacting with parents. And this is corneal assessment of pediatric delirium. More than 12 is taken as positive. His scoring was 16. However, these were managed with medical treatment, and child was finally transferred to ward on day 25. To summarize the case, child presented to us with complicated pneumonia, CT chest was suggestive of necrotizing pneumonia. He was on room air for 5 days, and then he was taken on right lower lobectomy was done, and post-operatively child came to pediatric ICU. He received mechanical ventilation for 1 day, following which he was taken on HFNC and NIV. However, because of air leak, bronchopleural fistula, subcutaneous emphysema, child was ventilated. He required very high settings, requiring high frequency oscillatory ventilation as well. The right middle lobectomy was done, and child was extubated on day 17 of admission. He was then taken on NIV, HFNC, and finally oxygen prompts, and then removed. Regarding infection, he was started on amoxiclav and linezolid for necrotizing pneumonia, followed by peptaz and vanco. And because of suspicion of HAI, he had features suggestive of ventilatory associated pneumonia, so he was upgraded to meropenem, colistin, vancomycin, followed by linezolid was continued. Total duration of antibiotics given was 4 weeks. Initially, child presented to pediatric ICU post-operatively in hypotensive shock. It was because of the massive hemoptysis. However, he also required ADR of 0.1, so there was element of septic shock as well. He received packed RBCs. Again, he developed shock on day 14 of admission, and this time he received noradrenaline. He was encephalopathic after extubation, and which was attributed to sedation withdrawal as well as ICU delirium. For sedation withdrawal, we tapered his fentanyl very slowly, 10% per day, and also started him on clonidine. For ICU delirium, we started him on risperidone. Although we do all the measures to decrease ICU delirium, like not restraining the children, keeping the parents with the children 24 hours, reducing the noise load in pediatric ICU in the form of alarms or mobiles, and keeping the lights dim at night. In spite of this, ICU delirium rate is still high. So these were the investigations in this child. As said, at admission to pediatric ICU, child was in shock because of hemorrhagic, because of massive hemoptysis, and he had a hemoglobin of 3.7 and presented with neutrophilic leukocytosis, a sodium of 132 and high CRP. Then when the child post-extubation, when he deteriorated and developed features of BAB, his sepsis screen in the form of CRP and ECT was positive, and his MAN2 was negative, 5 mm, non-bronchoscopic BAL, CB0 as well as AFB was negative. Cultures, all we sent repeated cultures when before upgrading any antibiotic, but all cultures, non-bronchoscopic BAL as well as blood cultures came out to be no growth. So I would now invite Dr. Taruna Yadav, who is additional professor in the Department of Diagnostic and Interventional Radiology, to discuss the CT chest of this child before surgery as well as after surgery. Over to Dr.
Good morning, everyone. So after a very stormy course, this was a 4-year-old child who presented with the suspicion of necrotizing pneumonia. So he underwent multiple investigations, but I'll be showing two CT scans that show his condition of the lungs really well. So this was the CT chest which was done before surgery. So as I'm scrolling here, you can see this is the trachea and larynx, which looks like normal. As we go down, so these are bilateral upper lobes which look normal. So this is the right upper lobe, which shows some infiltrates in the right upper lobe here. As you can see on the right side, the R marks the right side and the L marks the left side of the baby. So the right upper lobe has some infiltrates, but it is grossly normal. Then as we go, this is the right middle lobe which starts to appear, and you can see the right upper lobe, right middle lobe is completely consolidated with few areas of air bronchograms here, and the right lower lobe also shows cavitating consolidation changes with areas of breakdown and bronchiectasis. So as I go up and down here, you can see right upper lobe is relatively normal, but the right middle lobe and a significant portion of right lower lobe is abnormal. So right middle and lower is abnormal. So during the first surgery, non-segmental right lower lobectomy was done because during the surgery, the child started to desaturate and right middle lobe was left in situ. The left lung entirely was normal before surgery, as you can see. So left lobe was normal, only the right middle and the right lower lobe was abnormal. So he also underwent one more CT after the first surgery, and before the second surgery. So as we see here, so there is in the right side pleural cavity, you can see there is an air fluid level, which is the right hydropneumothorax. There are few mild infiltrates in the left upper lobe, which are normal in a post-operative child. And as I go inferiorly, here you can see, you are able to see the right lung parenchyma. So the right upper lobe, here you can see the right upper lobe bronchi. There is very little bronchiectasis starting to happen in the right upper lobe, as you can see in this area here. But grossly, the right upper lobe parenchyma is looking normal. As we go even further down, so this is the right middle lobe, which is completely replaced by this cavitating consolidation. So, and here we can also see there are multiple surgical clips in the right adjacent to the hilar margin along the right lower lobe. So all these are post-surgical changes. ICD is in situ, and there is some pleural peel, and there is hydropneumothorax. So right lower lobe had been removed. This right middle lobe, which was there, showed this cavitatory consolidation with an air leak from this right middle lobe segmental bronchus. Here you can see the bronchus is almost reaching up to the pleural surface. And this was the cause of his bronchopleural fistula with associated post-operative changes along the right lower lobe, and the left lung was relatively normal. There were few aspiration changes in the left lower lobe, as you can see here, but other than that, left lung was relatively normal. And he had some mediastinal lymph nodes, but which are expected in a normal post-op child. So status post right lower lobe lobectomy, hydropneumothorax with still persistent cavitatory consolidation in the right middle lobe and a bronchopleural fistula. This was before second surgery, and then he underwent another surgery in which the right middle lobe was also removed, after which the patient improved. So now I would request Dr. Daisy to tell you about the further management.
Thank you, Dr. Taruna. So the CT chest has been described very well by Dr. Taruna. So I will just advise of the histopathology findings after the biopsy. Features were suggestive of organizing pneumonia with interstitial fibrosis and follicular bronchiolitis. So the final diagnosis was necrotizing pneumonia with acute respiratory distress syndrome with bronchopleural fistula with healthcare associated infection, probable VAP, that is ventilator associated pneumonia, with septic shock, with ICU delirium, with subtotal pneumonectomy. So a child was transferred to ward on oxygen support, which was gradually tapered and stopped. MRI brain was done in view of encephalopathy and prolonged ICU delirium. A child was not interacting with guardian for more than 10 days, but MRI was found to be normal, and ICU delirium improved in 4 to 5 days of ward stay. Antibiotics were stopped after completion of 4 weeks. Bronchopleural fistula was still persisting, and the case was discussed with pediatric surgery and was transferred to pediatric surgery ward, where they attached a Heimlich valve to in the ICD, and child was discharged after 48 days of hospital stay. So here you can see how this Heimlich valve is attached to the ICD of the child, and child was sent home. However, 2 weeks after going home, there was accidental pulling out of the ICD along with the Heimlich valve. However, child remained asymptomatic and reported to OPD. So he was kept under follow-up, but as he was asymptomatic, he was conservative management was followed. And child is built up on his nutrition, and he's doing well now. So, concise review of bronchopleural fistula in mechanically ventilated children. We had, although we followed low PIPs, that is peak inspiratory pressure, low positive end expiratory pressures in this child, still he had a prolonged mechanical ventilation that was of 17 days, and also his BPM was persisting thereafter even for 2 months. So mechanical ventilation and intrapleural catheter management must be individualized and aimed at reducing air leak. Clinicians should emphasize reducing PIP, that is peak inspiratory pressure, reducing the positive end expiratory pressure, limiting the negative intrapleural pressure. In refractory cases, clinicians can consider lung isolation, independent lung ventilation, or ECMO. Yes. Or ECMO in appropriate patients, as well as definitive management with advanced bronchoscopic placement of valves or occlusion devices. But on Heimlich valve attached to the ICD, child improved, and we managed to send him home, and thereafter that was removed also. So coming to the fishbone analysis for the prolonged morbidity in this child, As we can see, there are psychosocial factors, because after the first admission there was death of mother, and so there was the grandfather was taking care of the child, and there was a few days of non-adherence to treatment that could have resulted in the non-resolution of the necrotizing pneumonia. Second factor was incomplete resection of necrotized lung. However, this was non-modifiable, as a child intraoperatively developed hypotensive shock due to massive hemoptysis, so they could not go ahead with the plan of the surgery as was planned, and so there was predisposition to BPF. Positive pressure ventilation and setting of air leaks. It is a double-edged sword. So this child, lungs were very bad, moderate to severe ARDS, and required very high pressures because the CO2 was very high, but then this was increasing the air leak. Healthcare of severe infection was another challenge that we faced in this child, although all the cultures came negative, but he had features of VAP, and so antibiotics had to be upgraded. ICU delirium was another factor which caused prolonged morbidity in the child. So even after extubation on day 17, child had to be in the ICU for another 8 days because of ICU delirium. So as I said, we take all possible measures to decrease ICU delirium, but still the noise level is not controlled as much as is desirable. So the ICU environment and the use of sedatives, the use of midazolam has been associated with ICU delirium. However, we refrain from using midazolam. Instead, we use dexmedetomidine along with fentanyl in our patients. So this child had ICU delirium, which persisted for long. Sedation withdrawal syndrome was another cause for morbidity in this child. And this was because of the long duration of mechanical ventilation requiring prolonged sedation. So many of the factors here are modifiable, and if we take care of these factors, we can probably decrease the prolonged ICU as well as the hospital stay in such patients. So finally, coming to the ICU liberation bundle, the A, B, C, D, E, F approach. So ICU is not only about mechanical ventilation and management of shock. A stands for assess, prevent and manage pain. B stands for breathing, that is both spontaneous breathing as well as spontaneous awakening child. C stands for choice of analgesia and sedation. You should understand the importance of depth of sedation and choose the right medication, and use protocolized sedation so that we don't give excessive sedation and analgesic drugs. D stands for delirium, assess, prevent and manage delirium. Understand the risk factors and find the tools for its assessment, treatment and prevention. E stands for early mobility and exercise. F stands for family engagement and empowerment. So now for long we are allowing parents to be 24/7 with the child, so that and even the family is involved. So it is now PFCC, that is patient and family centered care, and not the physician or just the patient centered care. The role of family is very important, even in decreasing issues like ICU delirium and sedation withdrawal. It helps in early better outcomes.
कागज नहीं आया क्या?
So I would like to acknowledge all the faculty and residents of the Department of Pediatrics, staff of PICU, as well as the Department of Pediatrics, the Diagnostic and Information Technology Department, who have helped in management of this patient. Thank you, and the house is now open for questions.
Okay, excellent presentation. Well managed case. Congratulations that at least child was saved, and both team, you and pediatric surgery, has done the excellent job. And really, air leak with ventilation is really problem, and it was though long course, but child is alive and well managed, and I congratulate your team for a wonderful effort you have made.
Thank you so much, sir.
If there is no more questions, can we call it close?
Yes, sir. We can just have a look at the chat box.
Okay.
Yes, sir. There are no more questions or comments.